Good evening, good afternoon, good morning, wherever you are around the world. Welcome to the monthly ILAE Africa webinars. My name is Edward Kija. I'm a pediatric neurologist from Dar es Salaam, Tanzania. And I'm happy to welcome you to our today's talk, which is going to be on the updates of developmental and epileptic encephalopathies. This evening, we are privileged to have one of our distinguished pediatric neurologists, Dr. Faith Mosha, who will be giving this talk. Dr. Faith Mosha is currently working in Malawi as a consultant pediatric neurologist with Baylor College of Medicine in Malawi, as well as involved in teaching at the Kamuzu Central Hospital, where she teaches postgraduate students at Kamuzu University of Health and Allied Sciences. Dr. Faith began her training in Tanzania at the Kilimanjaro Christian Medical College in Moshi, Kilimanjaro. And then she went on to do her MPhil in pediatric neurology at the University of Cape Town. Dr. Faith Mosha is involved with several professional networks where she works with the Pediatric Association of Tanzania. She works with Pediatric Neurology and Development Association of Southern Africa, PANDA SA, as well as the British Pediatric Neurology Association, BPNA, as a faculty and trainer for the Pediatric Epilepsy Trainee course. Dr. Mosha also holds leadership roles at the African chapter as the African chapter representative for the International League Against Epilepsy, the Young Epilepsy sections, or the ILAES. And she's also an African ambassador for the International Child Neurology Association, ICNA. Her clinical and research interests focus on epilepsy, early childhood neurology and development, as well as neurological infections in resource-limited settings. It's of great privilege to welcome Dr. Mosha to give us this talk this evening. Dr. Faith, you're welcome.
Good evening, everyone. Thank you so much, Edward, for the introduction. My name is Dr. Faith Mosha. I am a pediatric neurologist originally from Tanzania. However, I'm currently residing in Malawi, and it is my pleasure to give you all a talk on the current updates on the developmental and epileptic encephalopathies. Sincere appreciation to the International League for giving me this opportunity, and yeah, let's go through it. So this is the outline of my presentation. So to start off with, I'm sure you're all familiar with this figure, which was published in 2017 as a highlight of how to classify seizures and how to classify epilepsy in general. And to start off with, you at the top, you have your seizure types, which is mainly classified according to the onset. So you can have seizure types of focal onset, seizure types of general onset, and then there are the unknown box. And then after you are able to categorize your seizure types, you can go further, and then you can try and classify the epilepsy type into, if you are certain that you're dealing with a focal type of epilepsy or a generalized type, or you can have a combined both generalized and focal. And again, the unknown box features there. And then after this, there is the further classification where you put together your clinical and your electrical together with your possible underlying etiology, and you're able to put your findings into a specific epilepsy syndromes box. And cutting across all categories, you have your underlying comorbidities, such as your behavior issues, your sleep disturbances, and so on and so forth. And then you can have your etiology, because obviously during this time you're trying to find out the underlying cause of the seizures for your patient. So it can either be your structural, your genetic, infectious, all the way down to your immune causes. And also, again, you have the unknown box, where you are unable to identify a possible cause. So for today, we are going to be focusing on your DEEs, which fall under your epilepsy syndromes. So before I begin, I would like to highlight the recent key changes that has occurred under the International League in classifying epilepsy. And then you have your, basically the core framework of the 2017 version has been retained. However, there is now an introduction of 6 main changes, and these changes have been aimed at improving the clarity for basically your everyday clinical practice. So to start off with, number one, there is now a clear distinction between your classifiers and your descriptors when you're categorizing your seizures. And the main, I'll focus on, basically I'm going to state all the main 6 key changes that have been made within this recent couple of months. So basically you have your, previously we used to use the term awareness, impaired awareness, or retained awareness. However, this has now been replaced by the term consciousness as a classifier. And consciousness basically covers both your awareness and your responsiveness. And so you may have either preserved or impaired consciousness. So now that term is we're now using the term consciousness. And also the clinical semiology, the clinical seizure semiology has now been recognized as a very important aspect when you're describing seizures and when you're trying to classify the type of seizures and when you're trying to classify the epilepsy. And basically the chronological sequence of the seizure semiology has been given a lot more importance, rather than just relying on the first noticed symptoms that have been observed. So now a detailed chronology of sequence of ictal events to describe seizures is basically one of the main focus. And then coming down to your descriptors, the term motor versus non-motor has been replaced by observable and non-observable manifestations. And this has been updated so as to better reflect what can be witnessed during a seizure. So you have a better description to say, okay, these were the observable features versus non-observable manifestations. So last but not least, the term onset has been removed from the names of the main seizure classes. So motor onset, or that aspect of that word onset, has been removed, and now it's simply observable versus non-observable. And lastly, there has been introduction of a new seizure type that has been recognized. The league now recognizes the term, the seizure type epileptic negative myoclonus. And this is a new seizure type. Basically, it's a sudden loss of your muscle tone, therefore causing a very short period of either muscle weakness or floppiness. And this is characterized by visible epileptiform features on your EEG, either a spike or a wave abnormality. So this has now been introduced as a new entity. So moving forward, introducing the DEEs, we all know that the DEEs are a group of severe early onset epilepsies, and they are characterized by seizures that are drug resistant. Most of the time they're multi-drug resistant, and also characterized by developmental slowing, or you have an element of developmental regression, meaning that the child started off developing normally. However, with time, the development started regressing. They started all the things that they had started doing, they're not doing anymore, and they're sort of moving backwards. And they are also a high burden of neurological and systemic comorbidities that have been associated with the DEEs. Initially, they were classified as epileptic encephalopathies, which I will talk about in the next slide. However, with time and with advancement of research and technologies, and with understanding the possible underlying genetic and structural etiologies, this has led to a more comprehensive term, which we have which is now called the Developmental and Epileptic Encephalopathies. And this term was officially adopted by the League in 2017 and reaffirmed in the subsequent guidelines. So DEEs are classified according to epilepsy syndromes, which are basically a distinctive cluster of both your clinical and your EEG features associated with the underlying etiological findings based on the investigations that are done. They encompass many epilepsy syndromes. However, it is important to note that not all patients with a DEE can be classified or can be put neatly into a specific syndrome. There have been more than 900 genes that have been implicated in the cause, as well as structural causes, and this has led to the advancement of precision therapies, as well as novel therapeutic approaches, which have been done by research trials and the use of drugs and seizure medications that were already existing, and they've been repurposed, and also introduction of new drugs as well as gene therapies. However, we are at a very pivotal point where we can begin to tackle the therapeutic management of your DEEs in a targeted manner based on their underlying neurobiology, and therefore this has also caused an increased need to have a clear operational definition, so as we ensure that we are treating these patients with DEEs with the appropriate targeted precision trials for each individual individually, with targeted outcome measures. So just highlighting the evolution of our pediatric epilepsy syndromes, we have your developmental encephalopathies, where the developmental consequences of the underlying etiology is independently contributing to the developmental impairment. And then you have your epileptic encephalopathies, where the epileptic activity itself, meaning the seizures, are the ones that are causing severe cognitive and behavioral impairment above and beyond what might be expected from the underlying pathology alone. Then you have your DEEs, where you have developmental impairment related to both underlying etiology independent of epileptiform activity and the epileptic encephalopathy. So DEEs onset, if the onset is during the neonatal period, it's very hard as a clinician to be able to distinguish the DE from the EE, the developmental encephalopathy and the epileptic encephalopathy. I'll be using these terms, so that's why I put that slide so that we know what DE is, what EE is, and what DEE is. However, if the onset occurs during infancy, especially during late infancy period or during childhood, it is I wouldn't say easier, but it is it's more of a clear temporal separation between the slow developmental progress, which is your DE, and the adverse developmental consequences of a superimposed EE. And this figure just illustrates basically what encompasses your DEs. You have your etiologies, your genetic cause can be either, and then can also be either genetic or structural, which causes your developmental impairment, and also you have your presence of the seizures, and then, yeah, as I said, that's what encompasses your DEs. So throughout this presentation, I based this presentation on a summary of 3 main articles that I felt were very important, that have been released within the past year, highlighting the key updates that have been released concerning DEEs. So we have this paper published in Nature by Professor Ingrid Scheffer. It is an amazing paper, and it was published late last year. Professor Ingrid Scheffer and team We also have operational definition, also published by Ingrid Scheffer and team in Epilepsy in late last year, early this year. And this highlights basically what I did state before, that we need clear operational definitions to be able to manage these patients accordingly. So this paper focused on the operational definition of our DEEs to underpin the design of the therapeutic trials to be able to improve management of patients with a DEE. And lastly, the last paper that I have also focused on it was a publication in the Lancet by Dr. Nicola Specchio and team, and they looked into the expanding field of genetic DEEs and what is the current understanding and the future perspectives. So throughout this presentation, I highlighted and summarized all these three papers. So looking into the burden of DEEs, it is estimated that DEEs have a global incidence of about 1.2 to 1.5 per 1,000 live births globally. And they compose of about 30 to 40% of all childhood epilepsies. It's important to note that early diagnosis is very crucial. However, we all know that this is often delayed. And the highest burden is mainly seen in our setting, in the low to middle income settings. And this is mainly attributed to either misdiagnosis or a late diagnosis. It's very difficult to be able to tease out when a patient presents to you with certain clinical features. You're wondering, okay, what could this be? Again, we also have the element of patients presenting late when they're already in a more severe state. So there are a lot of elements that contribute to that aspect. There's also what we are all so familiar with, limited access to genetic testing. A lot of countries don't have that access. They have to send samples, or they have to network and send samples to countries that do genetic testing, such as either South Africa or Kenya, or send the samples to India. So all these are very, they lead to huge challenges that we face in our setting. And again, also poor access to anti-seizure medications and access to the advanced therapies that are available in the high-income countries that we don't have in our setting. In Africa, there's a huge data gap, and this is mainly, according to studies, it has been attributed to underreporting, as well as our diagnostic gaps, and also, a lack of population-based studies. So DEEs have a considerable burden on affected families. Not only the patient is affected, but also the families, the people who are taking care of this child, and as well as the healthcare system that is also assisting to manage these children. And this cuts across all areas in the world. It's a global considerable burden. And they're also associated with a high morbidity and mortality, with a severe impact on neurodevelopment, which we all know. However, with advances in genetics and neurodiagnostics, it has transformed care of patients with DEEs, especially in the high-income settings. However, in our settings, we're still struggling, and there's substantial disparities that persist in our settings. So these two figures just illustrate. I put these here because I found it so important to show how much of a burden children with epilepsy, especially with DEEs, can have. There's the element of your stigma, your discrimination. So you have your burdens on the overall health of the child, but then there's the other aspect of how much stigma these families face, and how much discrimination as well. And epilepsy is so much more than seizures. It's basically a huge umbrella with a lot of issues that come along with it. So there's been a marked increase in the recognition and diagnosis within the last decade. And as I said, this has been attributed to molecular genetic insights. And this has led to realizing that DEEs are actually much more prevalent than we thought. I just focused on two based studies that were done within the past 2-3 years. about 4 or 5 years. These were epidemiological studies that were done in Europe. One in Scotland, where they found that there was an estimated incidence of about 86.1 per 100,000 children, and this was done by Simmons et al., published in 2021, and they found that majority of these children had an onset by the age of 3. And then another one done 2 years later was a study done in New Zealand, where they found a cumulative incidence for DEEs of 1 in 590, basically it's 1 in 600 children presenting under the age of 16 years, with majority of those under the age of 3 being the majority group. So this has been a marked increase in the recognition and diagnosis within the last decade. I'm not as I say, this has been attributed to molecular genetic insights, and this has led to realizing that DEEs are actually much more prevalent than we thought, showing the cumulative incidence, as well as the type of methodology that was done, studies that were done within the research, and in what area. As you can see, majority about 4 or 5 years the publications were done in Europe, and these were epidemiological studies that were done in Europe. And you also have New Zealand. One in Scotland, but it also just shows that found that there was in high-income countries there's a lot of about 86.1 published studies that are done, and they're trying to tease out, and this is published in 2021. And they found that majority of these children had an showing how age of 3. And then another one done 2 years later was a study done in New Zealand, where they found a cumulative incidence for DEEs of 1 in 590, basically it's 1 in 600 children presenting under the age of 16 years, with majority of those under the age of 3 being the majority group. DEEs are. And this is something that we also in our setting need to consider, despite the challenges that we are facing. Yes, they are there. But however, we need to be able to highlight also the importance of the patients that we're seeing, as basically it can also be able to identify the presence of genes that have not yet been identified in the high income setting. So it's very important for us to also just focus on the research aspect to help highlight also how frequent the occurrences are. So looking into the etiology of DEEs, it varies all around the world. As I said, majority of the studies have been done in high resource settings. And from these studies, they have been able to identify that genetic studies currently have shown that genetic cause is encompassing more than about 50% of patients with DEE, and they have been linked to de novo or recessive and X-linked pathogenic variant mutations. The incidence of syndromes associated with de novo genetic variants is likely similar in basically all around the world. However, recessive cases are more of the cause of the genetic cause, especially in areas where there's high rates of consanguinity. In our setting, in resource-limited areas, the incidence of acquired, antenatal, perinatal, as well as early infantile structural brain injury is encompassing majority of the cause. So genetic DEEs are most commonly regarded as de novo, as I said. However, there are more genes that fall in autosomal recessive manner rather than a dominant inheritance, with a small number also following an X-linked or mitochondrial inherited pattern. So as I stated earlier on, that more than 900 genes have been implicated in the genetic cause of DEEs, and this link, I found it very helpful. The link for gene for epilepsy just highlights the more than 900 genes that have been linked to DEEs. Genetic DEEs implicate a range of disease mechanisms, And these may also be associated with structural changes in the brain, such as your malformations of your cortical disorders. And these result from changes in gene expression during early brain development, which I will discuss more in the subsequent slides. So these findings have reinforced the need to consider a genetic cause for all structural changes that are present in the brain. One of the most important groups of genes implicated in DEEs are genes encoding for ion channels, and their phenotypic spectrum is often explained by either a loss or gain of function of the ion channel, or you can have a mixed functional effects where you have situations where you have both gain of function and loss of function. But this just adds a more complicated, a more added layer of complexity in terms of how you approach the management and the treatment of these patients. And also explained by the need for targeting the predominant functional effect and to mitigate the risk that over-treatment can actually cause more harm. Basically, over-treatment may lead to the opposite functional phenotype. So again, this emphasizes the need to have carefully constructed research trials to detect whether our novel therapies positively or negatively influence the long-term outcomes. So touching a bit on the malformations of cortical development, as I said, studies have shown several genes that have been associated with structural mutations or structural causes of genetic DEEs. And basically, these genes are pathogenic gene mutation variants that have caused a disruption in the key neurogenesis processes, either during proliferation or during differentiation or during migration or during dendrito and axogenesis. And this figure just highlights some common genes that have been associated with mutation in different aspects of neurogenesis. So these mutations have been linked to cause neurodevelopmental disorders as well as intellectual disability in DEEs, and these genes are subdivided into subgroups by either by certain mechanisms, by different mechanisms based on their role in the pathogenesis. So either genes encoding for your chromatin modifiers, your transcription factors, or your RNA binding proteins, basically that control your process of neurogenesis. So don't be frightened by this this figure, but I put it so that you all understand basically the connections between gene mutations and functions, basically the clinical functions. So basically the blue on your right hand side, those are genes basically that have been associated with multiple epilepsy syndromes. So so the blue is your genes and the green is your epilepsy syndromes, and it just highlights the genetic complexity of epilepsy. The colors in between, your green, your blue, your yellow, it's basically used to connect to show which gene causes what. And if you can appreciate, there's a number of epilepsy syndromes where you have multiple genes that are linked with that type of epilepsy syndrome. So basically, it's just for you to understand how complex epilepsy can be, not just focusing on your epilepsy, not just focusing on your DEEs, but also other type of epilepsy syndromes. So there's an increased mortality risk related to DEE seizures and the comorbidities. And it is noted, it has been shown that DEEs that have seizure onset in early infancy have been associated with a higher mortality rate of about 50% dying by the age of 2, which is quite significant. And the primary cause that has been linked with the deaths is SUDEP. Other causes include your cerebral edema following a status epilepticus, chest infections, as well as accidental causes such as drowning. However, the SUDEP rates for different genetic DEE syndromes have not yet been well identified. It's work in progress. However, there's the exception of Dravet syndrome, whereby there have been extensive studies that have been done, and they have identified a Dravet-specific SUDEP rate of about 4.4 in 1,000 person years, and this has accounted for majority of the Dravet-specific mortality. Some studies have been looking into what could be the possible cause of SUDEP, and some studies have shown that there has been an element of cardiac dysfunction that occurs in patients with Dravet syndrome. However, there's no definite evidence that the high SUDEP rate is linked or has been or is directly linked to a cardiac basis. So it's important to know that different genetic DEEs vary considerably in their SUDEP risk. Coming to pathophysiology, so in the early 1990s, there was the first identification of epilepsy genes using family studies, your CHRNA4, your KCNQ2, your SCN1B, your sodium channels. So basically all these are basically ion channels, genes encoding for your ion channels. So with time, genetic discoveries have shed light on the possible disease mechanisms, and there's been a diverse function of genes highlighting a huge array of possible biological processes that interact at your cellular level, at your organ level, and at your network level. So again, I'm sure we're familiar with this figure that basically shows the critical components that define DEEs. So just taking you through it, this include one, you have your presence of your seizures and or your epileptic form activity on your EEG, and this contributes or it may worsen the neurological condition, causing either your developmental slowing or your regression. Two, evidence of developmental slowing or regression, indicating a huge impact on the cognitive and the motor function of the patient as a result of the condition. And three, you have an identification of an underlying possible cause, which I did state earlier. It could be genetic, it could be structural, it could be metabolic, or other factors contributing to the disorder. So basically this framework, it just emphasizes the interplay between your seizures, your epileptic form activity, your developmental slowing, basically your developmental impairment, and also the underlying cause. And it has helped to sort of highlight how complex DEEs are and how difficult it is to diagnose, and how important it is to be able to understand how or what happens with DEEs. So I really liked this this illustration. It was published last year by Prof. Ingrid Scheffer, that just summarizes the possible pathophysiology that, in terms of the biological processes that occur with DEEs, especially genetic DEEs, and they highlighted 4 key biological processes that have been associated with the pathophysiology. And you have your channelopathies, which is basically a dysfunction of your ion channels, either your sodium ion channel, your potassium, or your calcium, as well as your ion solute transporters. And mutations in any aspect of this part has been linked or has been shown to be implicated in as a cause of DEEs. Secondly, you have your synaptopathies, which is basically a disruption of your SNARE, which is your soluble N-ethyl myelamide sensitive factor activating protein receptor, and this receptor is responsible for your synaptic vesicle formation, your synaptic vesicle release, as well as synaptic scaffold proteins, and your postsynaptic receptors and signaling cascades. So again, this has also been involved in the development of your DEEs. Thirdly, you have your cell signaling and metabolism pathways. So any mutations that affect the genes that are involved in this aspect of your cell signaling and your metabolism, such as your mTOR pathway and your G protein receptor signaling, has also been linked. And lastly, you have your epigenetic regulation, where mutation in proteins that are part of the epigenetic machinery has been also shown to cause DEEs with a disruption in your chromatin and your transcription modification. So DEEs typically present during infancy or during early childhood, and their main features include patients presenting with multiple seizure types, of which they're so difficult to treat. You have patients who are on 3-4 anti-seizure medication trying to treat different seizure types that they present with. They also have EEG abnormalities. They also have global developmental delay or regression. And these patients often have other additional features such as your hypotonia. They may have autistic traits. They may have ID, behavioral challenges, as well as motor dysfunction. So for this presentation, I'm not going to go into each particular DE, as that was already done by colleagues in previous talks, but I just wanted to just highlight and show you in the recent publication done last year. Basically, this figure just shows the DEE epilepsy syndromes and their etiologies, and you can appreciate the epilepsy syndromes that occur in different age groups. You have your early infancy DEEs, such as your early infantile DEE, which usually has an onset of 3 months or less of age, and then as you keep moving as you keep moving forward, you have your epilepsy of infancy with migratory focal seizures. Then as you move towards 4 months, you have your Dravet syndrome, you have your infantile 3-4 months, you have your infantile epileptic spasm syndromes. And as you move across the age group, when you hit about 1 year, that's when you have many more DEs that have been associated with that. You have your Lennox-Gastaut, you have your EMAs, you have your FIREs, you have your PMEs, you have your Rasmussens, and you have your EMATs as well as your Landau-Kleffner. So this figure just highlights what are the common DEs that occur with different age groups. And as you can see, majority of the ones that occur above 1 year, they even cut across into childhood, even going up to adulthood above the age of 18 years. The colors also illustrate whether these DEs are focal DE syndromes in your blue. The yellow are those which have both a generalized or focal component, or also known such as your infantile epileptic spasm syndromes. And then you have your purple, where they have both components of focal and generalized, such as your LGS and your Dravet syndrome, because they present with multiple seizure types as well. And then you have your red aspect, and these are your generalized DE syndromes. So prominent role of genes have been implicated in DEs, especially in early brain development. And there has been a considerable contribution of the cause to be able to highlight the cognitive outcome. So the developmental impairment compounded by your regression or your slowing is inherent, and this is very inherent to DEEs. Also, with ongoing seizures and with worsening epileptiform activity, this causes worse outcomes if you have poorly controlled seizures, if your EEG constantly, whenever you do your EEG, the EEG looks terrible. This predisposes the patient to have worse cognitive outcomes. A lack of period of, so with neonatal and infantile DEEs, as I say, those presenting at an earlier age, it's very hard to tease out what came first. So, because you find in these patients, it's very hard, they don't have that normal development period. So if they have their onset early, they start having your developmental slowing and regression at a much earlier age, whereas those who have already started developing fine, and then they start slowing down or they start regressing. So this lack of period of normal development in neonatal and infantile DEEs makes it difficult to determine any additive effect of the seizures on the cognitive outcome. And there are clear examples where there are DEE syndromes that are clear examples where improving the seizures managing and improving basically the seizure control, or giving the appropriate anti-seizure medication to improve the EEG activity, to basically to cause resolution of the interictal EEG abnormalities, has been shown to improve cognitive outcome. And examples include your Dravet syndrome, where usually these patients are exposed to multiple seizure types, of which carbamazepine is one of them, because they present with multiple seizure types. You have your hemiclonic, they can also have focal. So these patients are given carbamazepine, and studies have shown that once you suspect that you may be dealing with a Dravet syndrome, stopping these patients on that specific medication may actually improve seizure control. So stopping them and then changing them and managing them on an appropriate anti-seizure medication designed or shown to improve seizures in that specific syndrome, which is Dravet syndrome, has been shown to improve seizure control and developmental gains. Another example is your Landau-Kleffner, where initially you have your onset of your EEG abnormalities, which is associated with an acquired epileptic aphasia. So basically they lose the aspect of speech. So managing these patients on their appropriate medication has been shown to basically have an improvement on their cognition, provided that they are treated with the appropriate treatment. And lastly, we all know with your infantile epileptic spasm syndromes, the earlier you diagnose these patients, the earlier you start them on treatment. That means they have a shorter time to stopping the spasms, and this has shown dramatically, and we've all seen those who manage patients with infantile epileptic spasm syndrome, it has been shown to improve your developmental outcome, provided that they are managed early. So historically, DEEs have been diagnosed on the basis of their electroclinical presentation, and they typically take time for the full syndromic picture to emerge, during which the child often starts showing developmental slowing or regression. However, with time, with advancements and technology, the diagnosis of a DE can now be made far more earlier, with increasing recognition of the initial presentation and prompt access to molecular diagnosis in clinical practice, even before the EEG starts showing abnormal epileptiform activity and even before developmental slowing occurs. So DEs include a wide range of epilepsy syndromes defined by age of onset, the type of seizures that they're getting, the features that you see on EEG, how their development is initially and how they progress with time during the course of illness, and also any underlying associated features. And the diagnosis, it helps to inform etiological investigations, and also with prognostic and genetic counseling, and also selection of appropriate therapeutic approaches. Etiology, as I said, etiology is frequently genetic, which may be associated with normal findings on your neuroimaging. However, we also do have structural causes, which may show either diffuse or focal abnormalities in your malformations of cortical disorders, and less commonly you have your metabolic features. Acquired causes such as ischemic injury, infections, and hypoglycemia, they have been shown to be acquired causes. They're a small group, but however, they're also very important, especially in our setting. For some of the rare syndromes, such as your Rasmussen syndrome and your FIRES, your febrile infection-related epilepsy syndrome, the etiology is still currently unknown. So our main aim in diagnosing DEEs is to identify both the DEE syndrome and the etiology in each patient, as basically they complement each other. So they provide a complementary information to help manage your patient better in terms of appropriate therapy and also the prognostic counseling aspects. So it helps to give a broader and a better understanding of the condition. Knowing the gene is not enough. because each gene is typically associated with a spectrum of phenotypes. If you recall the figure that I showed, you can have 3-4 genes associated with one epilepsy syndrome, and vice versa. So, for example, like pathogenic variants in the sodium channel subunit genes, such as your SCN1A, your SCN2A, your SCN8A, they cause DEEs, as well as self-limited epilepsy, such as your Dravet syndrome. You have your SCN1A. And they each require very different treatment approaches. So you need to be able to have that understanding so that you know how to approach and how to target accordingly. So a gene can be associated with different DEE syndromes that either reflect a gain of function or a loss of function. And the need for therapies with the mode of action tailored to the underlying dysfunction. I stated earlier on that many patients with a DEE do not fit neatly into a specific recognized epilepsy syndrome box. So therefore, it basically shows how complex it is, but note that they all do share an they all do share an increased risk of comorbidities as well as SUDEP, and this cuts across all DEE syndromes. And it's very important to be able to recognize how severe their condition is and the nature of it. So I did state before that, if you recall correctly, that with time, with advancement of genetic testing, it has been able to assist in diagnosing patients early and managing patients early, even before the onset of their EEG abnormalities, even before the onset of their developmental slowing or regression. So studies, there were 2 studies that, there have been multiple studies that have been done looking into genetic testing and doing random genome sequencing, of which the median time from seizure onset to actually getting the results was 37 days, which is very fast, literally within a month. And they tested children who presented during the infancy period, and they presented with seizures beginning less than 1 year of age. And they were able to identify the genetic etiology in about nearly half of these patients, 46% of 100 children, with a clinical utility in 56%, and prognostic counseling in 86%. So this has had a huge impact on the genetic counseling of patients who have been found with a pathogenic variant, and it has also assisted in guiding the therapeutic approach modalities. So access to genetic testing means that the affected patients, example for a patient with Dravet syndrome, are diagnosed as early as their initial presentation. So you have, if a child presents to you at the age of about 3 to 4 months, and they present in febrile status epilepticus with either your hemiclonic or your generalized tonic-clonic seizures, you can possibly clinically diagnose that this child may have Dravet syndrome. And this can be considered basically from the age of 6 months, when even before their development and their EEG have started showing changes. So basically during the time period when their development and EEG findings are normal. So targeting, this is our main focus, to be able to identify and to be able to diagnose these patients earlier instead of waiting until they have advanced in their disease and they present to you with developmental issues. So early diagnosis enables early targeted treatment with the most appropriate anti-seizure medication, and our main aim is to be able to control life-threatening seizures so as to improve the adverse developmental outcomes and the consequence of frequent seizure occurrence as well as status epilepticus. And several observational studies have shown that appropriate therapies have improved developmental outcomes. However, the long-term outcomes for majority of the DEEs is rarely normal, and a multimorbid picture remains usual. So early diagnosis also helps to avoid giving or administering anti-seizure medication that is contraindicated to the specific DEE, as we all know that this will worsen the seizures, and it will just make everything terrible. It will also show like a worse cognitive outcome. So, as I said, DEEs are far more complex than just seizure disorders. And multimorbidity diseases affect a wide range of systems. You have your motor dysfunction, you have your movement disorders, you have your psychiatric features, you have your behavior issues, you have gait decline, you've got mood disorders, you have GI symptoms, problems, you have respiratory, you've got sleep. And these form such a huge basis of the burden of DEEs. And as the child grows, majority of these comorbidities become the main concern. So as the child grows with time and okay, you have some form of seizure control, but then now you have this whole other aspect of underlying morbidities, and the parents are looking, you say, my child cannot sleep, or I am not sleeping, I'm only getting 30 minutes of sleep in a day, my child is not feeding well, they're not gaining weight, my child has respiratory issues, my child is very aggressive, my child is, so that becomes the main concern for these families who already have been able to manage the seizures. They've been able to adhere to what you have been advising, but now you have this other side now that you're dealing with all these underlying comorbidities. So during infancy, DEEs carry considerable consequences that require proactive clinical management, and from that initial diagnosis, these families experience huge grief, and it's such an overwhelming emotion, mentally, physically, emotionally, on these families and the caretakers. And they need intense support, especially, and not just in the initial aspect, but they need it all throughout. And especially as the children grow, and especially as the disease evolves, they need much more support to be able to move forward, they to be able to handle everything that comes with time. We all know the presence of internet and social media, having this easily accessible at our fingertips. Families are faced with far more information than ever before, and this has therefore empowered and daunted so many issues that could develop. So there's a lot of information on the internet. There's a lot of good and bad. And families can come to you with, oh, I saw this on Google, it says 1, 2, 3. Or I saw this therapy on Google, it says 1, 2, 3. And then now, like, they start giving you ideas that, oh, how come you haven't tried this, or how come you haven't tried that, why don't we try this? So this has posed a lot of controversy and a lot of challenge in managing these patients. So these patients need a holistic care approach, and they need a multidisciplined team. So it's not just the clinician, it's not just the pediatric neurologist. You have the clinician pediatric neurologist, you have your nurses, you have your rehabilitationalists, you have your school, you have also families, your aunties, your uncles, everyone who's involved in care of this patient. And they need guidance, they need support, and they need the appropriate specialists for management of different comorbidities that occur in these children, and it needs to be tailored specifically to that individual. It needs to be targeted specifically to that child, not one size fits all. So you need to really be able to sit and be able to understand what each child is going through and what each family is struggling with, and ensure that they receive the appropriate therapy and support and education and rehabilitation targeted to that specific child's level of function. So investigations, routine bloods, urine, and CSF tests, these are done, performed early in a child's presentation, and each testing is specific and tailored to the patient's presentation. So you have your blood tests such as your blood creatinine, your ammonia, your amino acids, your biotinidase, your uric acids. So it's a huge variety all right? So you can't be doing the whole array of blood tests or CSF or your urine organic acids for each patient. No, it needs to be specifically tailored to how your patient presents. And testing should focus on treatable conditions such as your vitamin responsive epilepsy, such as your paradoxin dependent epilepsies, and so on and so forth. So in our setting, it's very hard to be able to access all these tests. So availability, accessibility, sustainability, and also costs. So basically, this poses a huge challenge to be able to try and investigate what could the possible underlying cause be. So yeah, access may be limited to EEG, and you may only be able to do neuroimaging. And with neuroimaging, it's not only most centers have your CT scan. Access to a brain MRI is often also very difficult, and worse, even genetic testing. So that poses a huge challenge. So all patients with a DE, they need investigations to characterize that type of epilepsy and also to be able to identify an underlying etiology. So routine EEGs have been found to be very useful. However, the recent studies or recent publications has shown that routine EEGs incorporating your hyperventilation as well as your intermittent photic stimulation have been advised, as this has been shown to increase the likelihood of eliciting an abnormal epileptiform activity. So also the use of video EEGs as well. It's been able to, so video EEGs is basically having your routine EEG and you are able to have a webcam or a video cam to be able to visually see what is happening whenever a child is having a seizure during your care when you're doing the recording. And they have been proven to show a detailed characterization of the ictal episodes as well as your pre-ictal, but your ictal episodes, therefore adding useful information and to be able to distinguish these events. Are they epileptic? Are they non-epileptic? If they're epileptic, what exactly is the child doing? And you're able to characterize and you're able to describe the chronological seizure semiology. Because often it's very hard when parents come to you. Yes, they're able to describe, but if you just have your routine EEG, you have your electrographical findings, but having a video EEG is that you're able to also visualize and see what these children are actually doing during the ictal episodes, and you're able to classify and to categorize them accordingly. So EEG also during sleep has also been shown to provide additional findings that help to guide an epilepsy syndrome classification. And these EEG findings during sleep, for example, in your Lennox-Gastaut or in patients with your syndrome of your EE, so your epileptic encephalopathy, spike and wave activation in sleep, as well as your DEE, spike and wave activation in sleep. So basically the presence of your generalized paroxysmal activity, fast activity, and also your spike and wave activation in sleep. So this has helped to identify that, we could be dealing with these specific epilepsy syndromes, and this can therefore help direct and guide you accordingly. So neuroimaging, ideally, all patients should have a brain MRI, specifically a 3 Tesla. I think there's even now 5 Tesla. But however, in our setting is, again, very hard. If you're even able to get a brain MRI, that is amazing. And so this has been proven to be very useful, so to be able to exclude whether you're dealing with a congenital or an acquired structural brain lesion. Further studies such as your PET, your SPECT, functional MRIs are also very useful. However, they are very challenging to perform depending on, again, accessibility and availability. I would also like to highlight the importance of neuropsychology evaluation, because it is able to help and guide you in terms of being able to characterize the cognitive aspects. Upon initial presentation, and throughout, and you're able to see the changes over time. And also you're able to see, like if you've started management on these patients, you're able to see also what is the response of the specific therapies if you are able to compare the neuropsych evaluation initially, and then maybe like 6 months or 3 months after the onset of your management, you're able to do another neuropsychology evaluation. So you're able to compare and see, okay, how has the cognitive aspect been over time? So this slide just illustrates the importance of neuroimaging. So you have your brain MRIs in the first picture A, you are able to appreciate basically you have your extensive subcortical heterotopia seen involving basically your frontal as well as an element of your temporal aspect on the right side. The next one, B, basically shows polymicrogyria involving your left posterior aspect. And in D, you're able to appreciate quite significant left hemispheric porencephaly, and all these patients presented with focal epilepsy. So routine genetic testing often begins with a chromosomal microarray. There has been, at least in about 4% of patients with a DE, there have been identifiable causative copy number variants that have been associated with a DE. However, next generation sequencing has been able to transform our understanding and has enabled the identification of their cause in about 50% of patients. So now with time, genetic testing has moved from exome sequencing to genome sequencing, and this has really been able to open up the doors to be able to identify so many other genes that have been associated with DEEs. So it's important to note that some gene panels use exome sequencing. However, the analysis is only limited to specific type of genes that have been included in that panel. For example, with Invitae, you have like your epilepsy gene panel, and there's already a subset of genes that they've included in that. So you may have a gene that is not included that, but is one of the cause of your patient with a genetic DE. So in such instances, reinterrogation for the genes that have not been analyzed, you have to request. If you're thinking, okay, maybe I'm dealing with a KCNQ2, or I'm dealing with an SCN1A, or I'm dealing with an CDKL5, and it's not included in that panel, you have to request that, okay, can you please search for this? Can you please do testing for this specific gene? We all know that genetic landscape is constantly evolving with this discovery of new genes. And as I said, now exome sequencing is now recommended where feasible and where doable. And now the genome sequencing is now moved into clinical practice, and this has enabled the analysis of your inotronic and regulatory genes. The element of mosaicism has been also increasingly recognized, especially within the past recent years, as an important cause of DEEs, including your germline mosaicism as well as your somatic mosaicism. However, detection of low-level germline mosaicism in DNA requires a high-depth sequencing or specialized techniques. So basically, this figure just highlights the molecular strategies for the diagnosis of genetic DEEs. It looks complicated, but however, it helps to give a guide when you're dealing with the molecular aspect and the genetic aspect. So an important aspect of DEEs that I would like to highlight and that has come forth as a very important part in the recent years is reproductive counseling. This is very essential in a patient with a genetic DE. And as I highlighted before, that majority of the pathogenic variants have been shown to be de novo. However, high-depth sequencing of parental blood or salivary samples have found that about 8% of patients had a parent with low-level mosaicism. And parents with mosaicism, there's a specific percentage. So parents with the mosaicism levels of about 13% and below were unaffected. However, those who had higher levels were associated with presence of your febrile seizures and other types of epilepsy. When talking about parental mosaicism, this places the parent at an increased risk of having a second child with a DEE, as a small population of their sperm or their ova carry the pathogenic mutated variant. So it's important to note that testing their blood or their saliva may not yield anything, because you may find that the mosaicism is limited to their gonads. So therefore, you may test their blood or their saliva, and then you may come up with a negative result. But the presence of mosaicism is present, and it can be passed on either during fertilization, either through the sperm or the ova. So therefore, genetic counseling should always discuss the possibility and potential testing of a subsequent pregnancy, and this conversation needs to be had with patients, with parents who have one child and they want to consider to have another, or also with patients with a genetic DEE and they've survived into adulthood and they would also like to have kids. So if patients with genetic DEEs wish to have children, the recurrence risk also needs to be carefully discussed. So please, this is a very, very also essential component of the management of DEEs. So coming to the last component of my presentation, talking about management, it must focus on seizure control and also the underlying comorbidities. And as I stated, holistic approach involves a multidisciplinary team to be able to provide appropriate therapy to mitigate the developmental, psychiatric, and behavioral challenges that these patients face. So management involves basically improving seizure control, therefore you're reducing seizure burden, targeted precision therapy if possible and if available, avoid any precipitating seizure triggers, treating any acute seizures and also treating any occurrence of status epilepticus, targeting your comorbidities and managing them accordingly, improving the quality of life, and also involves their transitioning into adult services. So starting off with reducing seizure burden, we all know that the seizures in DEEs are usually drug resistant, and majority of these patients are on multi-anti-seizure medications, and they've had trials of other anti-seizure medications that have not worked, so as to be able to control seizures. Approach can be particularly challenging, as we have all seen for those who have managed a patient with a possible DEE. However, a lack of diagnosis may result in inappropriate prescription of an ASM, which can cause worsening seizures with potential adverse developmental consequences. So historically, anti-seizure medication treatment choices for DEEs were made largely on the same general principles of targeting the seizure type. So if the patient presents to you with a focal seizure, and you're suspecting, oh, this could be a focal epilepsy, and you start the patient on carbamazepine. However, you have not really interrogated the history, and you have missed some other underlying seizure types, and then you may find that you may be dealing with a child with a possible Dravet syndrome, and this child is on carbamazepine, and therefore you're just worsening the seizures. The mom comes to you saying, my child is still, actually the seizures are even worse ever since you started on carbamazepine. So basically that type of mentality has moved with time, with the understanding of DEEs, with the publication of research data, publication of the research trials, and public advancement in treatment approaches, advancement in novel therapeutic therapies that are available. And we now have guidelines, we now have protocols that have been published for specific DEE syndromes based on expert consensus, thanks to the league, thanks to a lot of experts and specialists who have been able to come up with guided protocols tailored to specific DEE syndromes to help guide you into knowing what medications to give and what medications to avoid. Sorry, excuse me. However, even when an etiological genetic diagnosis is made, meaningful change in the treatment paradigm has not yet been possible for most DEEs. And it's important to note that precision therapy should be considered from the day a genetic diagnosis is made, which again, it's very difficult in our setting to be able to identify, okay, you may suspect this child has Landau-Kleffner, or you may suspect this child has KCNQ2, but then you're like, okay, how do I access genetic testing? But however, just having that knowledge that, okay, I may be dealing with this specific DEE epilepsy syndrome, it can help you to be able to go and research and see, okay, how do we manage Lennox-Gastaut, or how do we manage infantile epileptic spasm syndrome? So traditional ASMs can be used as precision therapies when the functional effect of the pathogenic variant is understood. So targeted precision therapy, the use of sodium channel blockers, particularly carbamazepine and phenytoin, has been found to be efficacious in gain-of-function DEEs due to pathogenic variants in the sodium channel genes. But now these are different ones. So now we're talking about your SCN1A33 and your SCN2A184, as well as your SCN8A185, as well as your potassium channel genes such as your KCNQ2. So in this case, you are allowed to give your sodium channel blockers. Whereas if you're dealing with your Dravet, such as your which is caused by your SCN1A mutation, that is contraindicated. You are not meant to treat these patients with carbamazepine. So trials targeting specific channelopathies are being developed, such as for your KCNQ2 DE, you have your potent selective potassium channel openers, such as your retigabine or your ezogabine. When we're talking about your SCN8A DEs, you have your highly selective NAV 1.6 inhibitor. And then another example is your green 2B gain-of-function DEs, where there is the use of trials of selective GLU-N2B negative allosteric modulators. So there are a lot of research trials that are being done to be able to identify what could be the best novel or the best precision therapy for specific DEE syndromes. However, few evidence-based trials currently exist to guide therapy. Majority of these trials have been focused on orphan genetic DEEs, such as your Dravet syndrome and your CDKL5, your KCNQ2. So in this aspect, such as your Dravet, your LGS, your tuberous sclerosis complex, the efficacy in some studies is shown the efficacy of cannabidiols have been quite significant in reducing occurrence of seizures as compared with those who are not given a trial of cannabidiols. In Dravet syndrome recently, the use of soticlestat has shown a median reduction in convulsive seizure frequency. And also another example is in your STKL5 deficiency, a trial of ganaxolone has been found to be effective, or has been found to be effective in a median percentage change in a month's major motor seizure frequency. Other trials have been designed on the clinical experience, suggesting the efficacy in specific DEEs. Again, I'll talk about Dravet syndrome, the use of stiripentol, which has become much more available with time, but still quite hard to access. So stiripentol use in Dravet syndrome, randomized controlled trials have shown that stiripentol is more effective than clobazam, and it has also been shown to be more effective in association with clobazam. When you combine, if a patient is on sodium valproate and clobazam, and then you add on stiripentol, it has been shown to cause a further 50% reduction, therefore improving seizure control, therefore reducing the seizure burden. Another drug that we might have heard of is fenfluramine. Studies have shown that fenfluramine as an add-on therapy was associated with significant greater likelihood of achieving more than 75% reduction in convulsive seizure frequency. However, this is dose dependent. because we all know that fenfluramine also has adverse effects. Fenfluramine has also been found to be effective in managing some seizures in Lennox-Gastaut, such as your drop seizures as well as your generalized tonic-clonic seizures. So interest is growing in clinical trials of new or repurposed drugs that target orphan syndromes or gene-specific DEEs. And these trials target the altered neurobiological pathways, even though the underlying epileptogenic mechanism often remains unclear. For example, the use of mTOR inhibitors in drug-resistant focal seizures in tuberous sclerosis complex patients. Quite a number of RCTs of new or repurposed agents for epilepsy syndromes holds a good promise, and hopefully we'll be able to have positive outcomes. However, epilepsy syndromes remain clinically important because the consistent phenotypes may suggest pathways modifiable by a more broadly beneficial anti-seizure medication, and they may prove to be more economical viable than drugs targeting each gene disease. So I found this picture to be very useful because it shows what the future of personalized anti-seizure medication therapy may be. You have your investigations, you've done your neuroimaging, you've done your EEG, you've done your pharmacogenomics, you've done your genetic testing, and the use of AI. The use of AI to be able to process all this data and to be able to personalize specific anti-seizure or specific anti-seizure medications in terms of dosing and frequency to be able to improve the overall management of these patients. And also, again, if you see the picture below, there's also possibility of direct administering anti-seizure medication to specific restricted brain regions. So the future is wide. The future is endless. There's a lot going on out there. There's a lot that is being trialed. There's a lot that is happening. There's AI now that is also contributing to a lot of identification or a lot of assistance on what could possibly work. This basically just shows the new medical treatment. So this was published in 2021 of the new medical treatments of your DEEs. However, 3 years later, now we have even newer and emerging mechanism-based pharmacological treatment options. You have your ganoxolone, as I mentioned before. You have your soticlestat for your Dravet syndrome. You have fenfluramine is still there. You have your STK-001. So basically, this table just highlights the mechanism of action of these new and emerging medications. Basically, have they been FDA or EMA approved? What studies have been done, and what was the minimal effective dose? So this is the other aspect of the table. You have such as your fluoxetine. So this is just a summary of the mechanisms of action and the evidence of emerging treatment options that are being studied for various genetic DEEs. So another aspect of management is to avoid seizure triggers, and this is avoiding factors that cause worsening of seizures, such as environmental factors. We know with fever, with hypothermia, with hot weather, hot baths, this can trigger seizures in specific DEEs, such as your Dravet syndrome. Fatigue, stress or excitement, environmental fatigue or pattern stimulation. However, these factors vary between patients, and you really need to be able to identify what could possibly be a seizure triggering factor in each individualized patient. And this should be brought out when you're sitting with your patient and taking a detailed history, or during follow-up visits, trying to identify what could be the possible trigger, because a trigger for one patient may not necessarily cause a trigger in another. And instructions to avoid the precipitants should be provided to the families because they need to be made aware. Also, the use of inappropriate anti-seizure medications that can cause worsening of seizures, which I stated before, such as your sodium channel blockers as well. Next is also to be able to treat occurrence of acute seizures that occur in these patients, and also if they come into status epilepticus, because again, there's a high increased risk for patients with poorly controlled seizures to go into status. So the use of a seizure action plan, the use of a first aid, in and out of hospital rescue therapy, as well as in-hospital acute seizure management. This also has to be clearly defined when managing a patient with a genetic DE. Different genetic DEs have different risks of convulsive and non-convulsive status epilepticus and death. And understanding this helps to inform diagnosis as well as prognostic counseling and management strategies for these patients, and this includes recognizing and treating any precipitating factors. The earlier you treat and manage with appropriate anti-seizure medication, the less likely for them to go into status. And also the importance of adopting a status epilepticus protocol. This we as pediatric neurologists always advise, adopt a protocol that is suitable in your setting. Don't adopt a protocol that is been made in Australia and then you try and mimic and do the same thing when you have availability of different drugs. So it's very important to see what you have in your setting, to be able to identify, okay, this is the anti-seizure medication that we have available. These are the guidelines that are there for status epilepticus. How can we adopt this in our setting? What drugs do we have that are similar that we can put, and being able to come up with your own protocol and setting that up in your setting, that will eventually help to reduce the mortality and morbidity, not only for DEEs, but also for patients with epilepsy or patients with seizures overall who come in with status epilepticus. It's important to know that little evidence to show that any of the numerous recommended protocols is better than the other. At the end of the day, as I said, adopting a protocol specific to your setting, that is the best approach. So, talking about in and out of hospital interventions, the main options for out of hospital intervention include your benzodiazepines, such as your midazolam, your diazepams, your lorazepams, and again, depending on the formulation that you have, if you have buccal, if you have nasal, if you have sublingual, if you have oral, and being able to adopt that and being able to use it in your setting. Pre-hospital benzodiazepine administration may be effective in controlling repetitive seizures or status epilepticus and may avoid hospitalization. And this has been adopted in some hospitals where you're able to come up with a seizure action plan and be sitting with the patients, sitting with the parents, sitting with the caregivers, and be able to come up with a seizure action plan which involves pre-hospital rescue therapy to be given depending on the presentation of the child. Or most mothers know, okay, if my child starts behaving this way, this is them starting to have a seizure, and probability of the seizure stopping is very low. So mothers and caregivers know. So sitting with them and being able to understand and be able to identify and be able to say, okay, maybe in this patient they will benefit from having a rescue therapy before coming into hospital, being able to give this. Therefore, this reduces the likelihood of them going into status, or therefore this reduces the likelihood of them having repetitive or prolonged seizures. Again, it's important to highlight that overdosing should be avoided. So you need to tailor specifically to how much in terms of dosing and how frequent. Because if you overdose, that can also lead you down a path that you do not want to go through. Because of the increased risk of respiratory depression, patient may come in needing ICU, needing ventilation. So that is also another important aspect that needs to be highlighted. Severity of epilepsy in patients with a DEE should not reduce the focus on comorbidities. Comorbidities play a huge role and they carry a huge burden. Leave aside the occurrence of seizures. So you have, as I stated before, you have your mood disorders, you have your behavioral issues, your sleep issues, and these occur very frequently in patients with DEE. The etiologies are multifactorial and reflect the underlying neurobiology of the DEE. However, this can be exacerbated by poorly controlled seizures or frequent epileptiform activity on EEG, the effects and psychiatric effects of your anti-seizure medication, restrictions, social stigma, and social discrimination. So it's quite a number of factors that are attributed or that cause the comorbidities. There's a high risk of the typical medical complications associated with severe neurodevelopmental impairment. You have occurrence of aspiration pneumonia when a patient comes in with repetitive seizures or in status, very high risk of aspiration pneumonia, issues of feeding issues, constipation because they're not feeding well, sleep disorders because they're unable to sleep due to the underlying DEE itself because of the neurobiological processes, or also the use of the anti-seizure medication that they're taking, orthopedic deformities that may occur as well. So it's therefore very essential to have a multidisciplinary team to be able to address the care of patients who are affected, especially those who are severely disabled. Patients with severe behavioral disorders may benefit from a trial of pharmacological treatments such as your risperidones or your SSRIs. However, it's very careful to discuss this with the parent or the caregiver or the person taking care of the child on the possible adverse effects that may come along with managing these severe behavioral disorders, and also important to note what the drug-to-drug interaction may be with the current anti-seizure medication that they're on. So it needs very careful consideration and very careful discussion, because you don't want to worsen any seizures, and then there's also other side effects such as sedation, such as weight gain, and so on and so forth. There's also the aspect of forced normalization. So with time, if you're able to control the seizures, then the patient is not having frequent occurrence. However, this may bring up other occurrence of psychiatric problems that were not there before. And this commonly occurs in patients who have had a long-standing history of drug-resistant seizures, and finally you've initiated them on maybe 2 or 3 medications, and one of them is doing a really good job in managing the seizures. However, mom comes to you and say, now I'm dealing with a behavior issue, or now I'm dealing with a sleep issue. So this definitely does happen. And this figure just highlights what the common comorbidities are in patients with DEE. You have your cognitive impairment, which it's obvious, but you also have the sleep and sedation. They can either be insomniac or they can have increased somnolence. They can have sleep architecture abnormalities, staying up the whole night and being asleep during the day, so everything is just messed up. You have your mood or psychiatric issues such as depression. Sorry. Yes. So looking into, apologies for that. So looking into the quality of life, the quality of life measures extends to parents, carers, and families with lifelong caregiver responsibility and burden. And this addresses important personal, societal, and health economic consequences of the disease. Several studies in DEEs have demonstrated considerable worse health-related quality of life than in both the general population and in unselected childhood epilepsy cohorts. Highlighting important ones is your Dravet syndrome. Several studies have shown a more depressive symptoms, a greater financial burden on the caregiver, especially if the caregiver is female. In LGS, there's constant anxiety, difficulties in accessing childcare, and social life restriction, as well as poor mental health. But overall, the classification of epilepsy syndromes, your DEEs, has enabled condition-specific patient advocacy groups to form, and this has helped to facilitate research participation of carers and caregivers, as well as emphasizing the importance of sleep, communication, behavior, daily activities, motor skills, and language problems, which often eclipse seizures in importance as the child grows. So the last aspect, which is also a very important aspect, is transitioning. This is usually one of another big challenge that we as clinicians face, how or when to transition this patient when they reach of a certain age. And it's not only stressful to us, but it's even more stressful to the patients themselves as well as their caregivers. So transition to adult care is a particularly stressful and anxiety-provoking period for caregivers. And studies that have been shown, there's one that looked at people with tuberous sclerosis complex who developed epilepsy during childhood. And 75% felt that the disease led to isolation and social withdrawal and negatively affected relationships. And only 15% of respondents were actually optimistic about their state of health over the next 5 years. Although 90% of adults with TSC, with your tuberous sclerosis complex, they remained on anti-seizure medication. However, almost 40% did not have neurological follow-up. Therefore, this highlights the need for a supportive medical framework into adulthood, because you may have adopted an amazing framework for your patient all throughout their pediatric care. However, when they reached of age and then you said, okay, now we need to transition this child into adulthood, that's when the issues, come through. And that's when you have a lot more responsibilities. That's when you have a lot more medical issues that arise. So it's that transition period that is very, very important to think about when your child is about to come of age, and to start having these conversations with the patients and the caregivers and everyone involved in their care. So closing off, the key highlights of DEEs, they have a vast array of mainly genetic etiologies, and these alter different developmental processes and aspects of neurocell functioning. However, there is a shared consequence in impairment of higher cortical functions, as well as, and this is basically on top of the drug-resistant seizures that these patients have. Although severity varies across and within specific epilepsy syndromes and genetic diseases, you have a huge long-term impairment of overall cognitive, language, memory, attention, and executive functions. And it's important to note that almost all patients having cognitive impairment will have features of ASD as well. There's increasing awareness that anti-seizure medications mitigate epileptic activity. However, this does not adequately address the widespread cortical dysfunction resulting from the defective developmental processes, the neurogenesis aspect, and severe epilepsy. With prompted efforts, the use of repurposing drugs and also development of new molecules and precision treatment approaches has been able to broaden the therapeutic aspect and the therapeutic goal of curing not just the seizure disorder, but also managing and assisting with the comorbidities. The promise of gene therapy is imminent. In the direction that we're heading to, there's a lot of advancements. As I say, there's a lot of new discoveries. However, many limitations exist regarding implementation. Dosing is still a very, very important issue. Dosing of anti-seizure medication is still a very important issue, as you need it requires a very delicate balance to ensure that a gain of function phenotype is not turned into a loss of function phenotype, which can happen with some anti-seizure medications and in some specific epilepsy syndromes. And also, many genes demonstrate severe phenotypes with both types of dysfunction. So this therefore causes an even more complex aspect in terms of managing these children. The optimal timing of gene therapy administration is still unclear, as it depends on the type of DEE that you're dealing with, and it depends on the underlying mechanisms as well, and also the clinical presentation. DEEs have, by definition, developmental effects which are unlikely to be reversed postnatally, and limitation is likely to apply to developmental genes, receptors, and channels. And also early postnatal delivery of gene therapy is probably too late to fully reverse the formation of the abnormal brain networks that have already formed. There's a widespread nature of neuronal dysfunction typical of DEEs, and this requires a delivery system capable of targeting the whole brain in a critical period before mature connections are in place. However, overall, despite everything that I have said with the challenges and everything else in between, the future is far brighter for patients with a DEE than ever before. As in the past 23 to 25 years, we've moved from considering that DEEs are acquired disorders to identifying a possible genetic etiology underlying the DEE in at least 50% of patients. And what are the future perspectives? We can explore what role environmental factors have, such as your viral infections or your immune dysfunctions. And this is likely to illuminate phenotypic differences further. Also, development of precision therapies will hopefully lead to dramatic improvements in the outcomes for patients with a DEE, with the ultimate expectation one day of a possible cure. And all this will only be possible if we also do our role. In resource-limited settings, if we can also try get some research studies for our population to be able, as I said, who knows, we may be able to identify new genes that have not been identified before, and this can also help guide further in the management of our patients in our settings. So the future is bright, definitely, and we need to focus on what you can change for a brighter future, and we all have a lot of choices. We just need to know which one to choose at the end of the day. So with that being said, thank you all so much for listening and wishing you all a lovely evening. Thank you.
Thank you very much, Faith. That was very marathon of a talk, very elaborative, and thank you very much for summarizing a very complex topic into a way which someone will be able to follow. So we'll dive into the questions. We're diving into the questions now. We already have a couple of questions on the chat. So I'll ask all the attendees, if you have any questions, please put them on the Q&A section, and I'll read those questions for Faith to be able to respond. So right away, without wasting more time, I'll go to the first questions. It's coming from Nada Benkirane. So Faith, this one is asking, in resource-limited healthcare settings, how do you prioritize genetic testing and metabolic investigations for patients with DEEs? Do you recommend proceeding directly to whole exome sequencing, given its cost effectiveness compared to targeted gene panels?
Thank you, Edward. So in resource-limited settings, it's very hard because it depends on what you have available in your setting or what you can access. It's now recommended, we're actually shifting from exome sequencing to genome sequencing because we all know how restricted exome sequencing is. It's basically just 2% of the gene. However, if you're looking at genome sequencing, at least you have a wider array of a number of genes that you can target within that area. It all depends on what you have accessible. We would rather recommend whole genome sequencing if you have that available, if you can access it. However, yes, whole exome sequencing has been advised to use where feasible, because again, targeted gene panels, in my presentation, I did say there are already a specific set of genes that have been involved in that panel. However, if you're thinking that your genetic DEE is from a particular gene, that may not be part of that panel. So it all depends on what you have available and what you can access.
Thank you. So the next one, Faith, is in low-income resource country, how would you advise on genetic investigation testing where there is poor access and how to counsel and convince parents on genetic diagnosis of DEE?
So that is a very good question, because this is the situation in majority of countries in low resource settings. And how to tackle it, again, it depends on how you can access, where you can get genetic testing done. If you are able to network and to link with a certain person or certain company that you know, even if it's outside your country, to say, okay, I have a patient with this and this. I need to find a way to do genetic testing, and they can advise accordingly. I think the importance is to be able to network and to connect with as many people as you can. There's a lot also available online. If you can just Google nearest genetic testing near you in terms of which country is nearby. And it's important to also have that conversation with the parents and be transparent on how hard it is and how challenging it is to access genetic testing and what are the possibilities, and allow them to be able to decide, okay, if we're going to do genetic testing outside of a certain country, what are the costs, and have that long conversation with them. So it's all comes down to networking. I don't know, Edward, what are your thoughts? Because we are both based in resource limited settings with the disadvantages of no access to genetic testing.
Yeah, so they are quite challenging, the issues of accessibility, the issue of availability and accessibility. I understand now in many of the low resource settings, there are private labs which can take samples and will be able to send somewhere where the genetic testing can be done. But always the difficult question is, what do you do after once you get the results? Because some parents will say, okay, once I've paid this amount of money, will it going to change significantly, what will happen to my child? So it's that kind of conversation which needs to be done. As you correctly put it, it's important to manage expectations, that this test will be able to answer certain questions in terms of what to expect, in terms of prognosis, but it may not completely reverse the process, because in some cases, parents might expect, once you have diagnosed, let's say, KSNQ2 or CDKL5,
exactly,
then you'll be able to reverse everything that has happened to the child. So it's quite important to manage expectations, and again, let the parents be able to make the decisions.
Yeah.
So
it's
in the
very
interest
important to
of time,
set realistic expectations. Yes.
exactly. So we'll go to the next questions. Are there anti-seizure medications to be avoided during the diagnostic workup to prevent potential seizure exacerbation in patients with unconfirmed etiologies?
Okay, I'm not sure if I understand this question, but maybe I think the best thing is when you have a patient presenting to you with a possible DEE who has multiple seizure types, it's important to tease out what seizure types they have, and also what medications they are on, because if they're on the wrong medications, that is automatically going to cause seizure exacerbation. But during diagnostic workup, I am not familiar with any medications that are to be avoided, because at the end of the day, you want your child to be safe. At the end of the day, you want your child to have some considerable seizure control. So I'm not familiar with any anti-seizure medication to avoid during diagnostic workup, but it's mainly during your clinical assessment, and when a patient presents to you, you need to have the knowledge to know, okay, maybe I'm dealing with a gain of function or loss of function, and which medications to avoid.
Yeah, I think just to add on what you're saying, so I think the most important is the phenotypic characterization of the patients.
Yes.
Which in most cases, in most of the low resource settings, that is the best that we can do in terms of looking at other tests which we've got limitations. So it's the phenotypic characterization. And then if you have if you suspect a particular phenotype, and then you know that particular phenotype might be exacerbated by particular type of medications, then you may avoid those medications until you have completely confirmed the diagnosis that that medication can be used. So for example, if you're phenotypically characterizing a DEE and you think it could be a Dravet, then you may say, even though I've not done a genetic test to confirm is a SCN1A mutation, then you will avoid carbamazepine until you have confirmed that it's not Dravet. and then maybe
Absolutely.
that patient can be used. So I think the
Yes.
phenotype characterization, it's quite important, particularly
Very.
setting where some of these genetic and metabolic testing cannot be done quite easily.
Yes.
And then the next one says, what is the role of genes in epilepsy, and what are the most used tests to diagnosis? I think you've touched a bit, but maybe you can respond as well.
Because this is a very broad question, because epilepsy is huge. And the role of genes has really, as I said, over the years, it's really enlightened us on what genes are associated with specific types of epilepsies. And this has also led us to be able to know what targeted medications to use or what medications to avoid. So for that question, the role of genes has really played a huge role within the past 25, 30 years in the history of epilepsy as compared to where we were and how we are and where we're heading. The role of genes will continue to have a big role in epilepsy, in basically targeting your management and assisting with any, having that prediction of what may come, because you are aware, okay, I'm dealing with a specific gene, and this gene is associated with this type of seizure types or this type of comorbidities, and even during adulthood, so you're able to have that prognostic and genetic counseling aspect even to the caregivers and to the parents.
Thank you. So next one says, thank you for the elaborate presentation. This one says, I need a clarification. Do children who had asphyxia at birth, who now have cerebral palsy and seizures, fit into a diagnosis of DEE?
So asphyxia as asphyxia in general, if you're talking about asphyxia with severe HIE, this has been shown to be one of the causes of acquired, the acquired cause of a developmental and epileptic encephalopathy. But in general, if you have a child with asphyxia at birth, and then they now have CP and seizures, you shouldn't just automatically say this child has a DE, but you really need to go back and take reassess the clinical aspect. What is this patient presenting with? Is this CP? Is this something else? Was the asphyxia the cause of the CP, or are we dealing with something else? Because there are a lot of CP mimics that can present basically very similar. And asphyxia, it's a very broad term, so you need to really it depends on how your patient is presenting and what happened exactly. Did this child have severe HIE, or was there something more, or are you dealing with something else? So again, it all goes back to your clinical assessment, taking a thorough history, doing a thorough examination, and then also doing some investigations and see, okay, am I dealing with this or am I dealing with that?
Thank you. We are running short of time, so I'll go quickly to the next one.
Sure.
Do we know whether cognitive deficits in adulthood are due to critical periods of development that have passed, during which there were crises, or whether we have self-perpetuating processes that further aggravate the situation in adulthood?
Okay, so I'm not sure if this question is pertaining to DEEs or just in general. So it's not very clear, yes, because it's also, again, it's a broad question. Cognitive deficits due to what? Because it depends, what did this person go through during pregnancy, during early infancy, during childhood, that may have caused this cognitive deficit. So I'm not quite sure how to answer that. It's a very broad question.
Yes, thank you. I think it's out of context, so in the interest, we'll proceed. So thank you for your presentation. How common are the vitamin-dependent epilepsies, especially in Africa, and what is the approach to diagnosis?
How common are vitamin-dependent epilepsies? To be honest, I haven't, I do not know how common they are, because I know there's a huge data gap, and I'm not sure how much research has been done on vitamin-dependent epilepsies in Africa. However, your approach to diagnosis, you start from the beginning. You start from your clinical assessment all the way down to your examination findings, your biochemical testing that are involved, such as your biochemical markers that are very particular to your your vitamin-dependent epilepsies. And then coupling all that, if you have access to genetic testing, if you, such as your ALDH7A1 gene that has been associated with a lot of one of the vitamin-dependent epilepsies. So start from the basics, then go down according to what you find and how your patient has been presented. In terms of how common, I'm not sure, Edward, if you can enlighten that.
So we don't have data, whether be it hospital-based or definitely not population-based data, but we have anecdotal experience that the most common one that is the paradoxin-dependent epilepsy.
Dependent epilepsy.
Quickly out of top of my head, I think we've had like 3 in the past year in our clinical practice. And again, the way you diagnose again is phenotypic characterization of the patient. And then if they don't respond particularly very early, then we do the trial of paradoxin. And then if they work, then you have your diagnosis, since we have limitations in testing. So the next one, again, in the interest of time, thank you very much for your elaborate presentation. How common in your practice do DEEs occur in more than one sibling, and how common do they have similar phenotype?
Okay, so this I will have to answer based on just clinical experience. I have seen patients with DEE. However, in the sibling, you may find they have normal development, or they may have mild intellectual disability. And again, it all depends on how or what underlying gene is related, and what underlying genetic mutation and the variant, and how severe or how extensive. So it's quite tricky. But it's very important, if you do have a patient coming in with a confirmed or a possible DEE, to ask the parents if they have another child, and to bring the child in, and for you to assess and make sure that you're not missing, or you're not sidetracking this child just because the child looks normal and the child behaves normally. They may also have some key features that may be missing. In your experience, Edward, how common do you see in siblings?
So again, it's again, we don't have proper data, no population-based study or hospital-based study that I'm aware of. But there are some patients that we see will come with DE and epilepsy, and of not the ones that we are seeing, mostly they will also have some autistic features. So they will have epilepsy, they will have developmental impairment, and part of the comorbidities will be autism. And in my practice, we've seen coming from the same mom and dad, and some of the parents will also be siblings. And I've seen patients where 3 siblings also have children who have got similar phenotype. So it does exist. So the last one, I think I'll take this as the last one for the day. This is a quick one.
All right. Okay.
Is there any role of phenobarbital in resource-limited settings?
Yes, there's a huge role. It's the famous drug. It's the drug that we have that is most available, most affordable, most accessible, and it is used widely. It is in our protocols. It's in status epilepticus protocols. It's the first drug of choice that is given to most patients presenting with seizures, regardless of what their clinical phenotype is. So it's the one drug that it's the wonder drug. It works. But obviously you also need to be very careful that if a patient is on phenobarb, to just sit and find out the clinical seizure semiology and their phenotype, and if need be, you need to change basing on what they're presenting with, or or what you're suspecting. But yes, we use it widely a lot.
Thank you very much. The other one is just an appreciations. Nice presentation. So we've come to the end. In the interest of time, I think we are a few minutes before we've closed. So before we close, so the information for everyone. So the Global Health in Epilepsy Project database provides a registry of existing epilepsy projects throughout Africa and Eastern Mediterranean, as well as in other regions. It identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. The database will provide you an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of other sectors. Furthermore, the database will allow people from different areas such as the government, academia, nonprofit, or philanthropy to learn about existing efforts while offering a means to engage. So on the next slide, please scan the QR code to receive your certificate. And also there's a link in the chat box now for your certificate. So I'd like to take this opportunity to thank everyone for attending this very important session. And I will be on the lookout for our next session in the next 1 month, and hope to see you again soon. Everyone have a blessed and good evening, morning, or afternoon, wherever you are around the world. Thank you very much.
Thank you.